Lovely, thank you. So I'm just going to briefly run through an issue relating to bone marrow transplantation, and that is the patient who's referred to ICU. And what should I ask when I'm referred that patient? The reason this is important, I guess, is a lot of bone marrow transplant patients do end up in the intensive care unit. And the differential diagnosis for these patients is often incredibly broad. And a classic scenario is really respiratory failure, where often the differential can be incredibly broad, from sepsis through to a range of immunological phenomena, pulmonary edema, cytokine release syndrome. And to make matters worse, when these patients arrive in the unit, they usually have a medical note full of lots of crazy acronyms which are completely unknown to most of the staff looking after them, which seem of little consequence and importance. And so you can have a scenario where you have patients who seem very similar, who present the characteristics of the transplant they've had and what stage they're at. And so a scenario where people have respiratory failure, all these letters and times post-transplant may actually give you a clue before you've even clinically assessed the patient. So what do you want? What do I want to know, and what should you guys really want to know when you first referred one of these patients? I guess a simple approach is really, is it an autologous stem cell transplant or an allogeneic stem cell transplant, and what is the donor source if it is an allograft? So to summarise, an autologous stem cell transplant is essentially high-dose chemotherapy to treat usually a haematological malignancy, followed by infusion of stem cells from that donor, a short period of neutropenia, usually less than 10 days, and then a post-engraftment phase. While an allogeneic stem cell transplant essentially involves a conditioning regimen, a neutropenic phase, pretty similar, sometimes a little bit longer, a post-engraftment phase, but the major difference being the stem cells are infused with T cells from an alternate donor, from a sibling, an unrelated donor, or mismatched family member. And the consequence of that is this process of graft versus host disease, where this new immune system can induce illness. And as a result, there's lots of immunosuppressive therapies required, and there's a delayed immune reconstitution. So autologous stem cell transplants tend to have issues related to infection, predominantly neutropenic sepsis from bacteria, fungal infections, really quite uncommon in this type of transplant. Chemotherapy-related toxicities are very common, so enterocolitis and pneumonitis, and the treatment-related mortality is quite low, while an allogeneic stem cell transplant has a higher risk of death, in the order of sort of 10 to 25%, despite all effective measures. And the donor source can give a bit of a clue to what that risk of graft versus host disease might be. So a sibling having the lowest risk, a mismatched unrelated donor having the highest risk. Umbilical cord blood units can be used, and these patients tend to have a long time till their bone marrow recovers, which is pertinent in the setting of sepsis. And haploidentical transplants from children or parents, only half-matched, are more immunosuppressed and have this phenomenon, cytokine release syndrome, occurring in the first 4 days. So the second question that's reasonable to ask is, what phase are they post-transplant, what day are they? And this is pertinent because graft versus host disease doesn't occur in the first 6 to 7 days post-transplant. Cytokine release syndrome, or CRS, occurs early, particularly after haploidentical transplants. Organ dysfunction before day 6 plus 6 post-transplant essentially is nearly always infection, drug-induced or fluid-related issues. While later consequences out after 12 months are usually driven by chronic graft versus host disease and infection, often by invasive pneumococcal disease or community-acquired respiratory viruses. So the phases post-transplant can be useful to guide that differential diagnosis. In that early conditioning neutropenic phase, we generally have infection from bacterial translocation from the mouth and gut, line-associated sepsis, fungal infection potentially in about 10% of patients. Pneumocystis really is uncommon in the first 28 days due to the use of Bactrim prior to stem cell infusion, so it's really down the order in the early phase for respiratory failure. And treatment-related toxicities such as veno-occlusive disease and alveolar hemorrhage occur in the first 21 days. Acute GVHD classically occurs from about day sort of 14 out to about day 30 to 40, and CMV really follows or is closely associated with the development of acute graft versus host disease. So the other question is really when is engraftment anticipated? Is it days versus weeks? And this is merely of prognostic significance when a patient presents with severe sepsis. The fourth question is really what sort of conditioning regimen has the patient had? And whilst this is where it gets complicated with all these letters, TBI, flu TBI, the question that's reasonable to ask is it myeloablative or MA, or is it non-myeloablative? And that's the least intensive form to the most intensive form. So myeloablative conditioning regimens really have a high likelihood of inducing early tissue injury, acute graft versus host disease, while non-myeloablative regimens take some time to develop acute GVHD. So those landmarks are pushed back further, and early issues are less likely to be significant. The other part of conditioning is potentially asking what part of it is, and there's some keywords that stick out like total body irradiation, because this is a driver of potentially graft versus host disease or diffuse alveolar hemorrhage. When someone has hyperbilirubinemia, the key thing to think about in the conditioning is busulfan, which is the primary driver of veno-occlusive disease after an allogeneic transplant. ATGAM or antithymocyte globulin can cause a pulmonary toxicity, and high-dose cyclophosphamide can cause a cardiomyopathy, usually both of these within days of their delivery. Associated with this conditioning regimen, it's reasonable to think, is it T-cell depleted or not? So the T cells are those donor cells that drive all the immunopathology, and this can be done either in the patient using ATGAM or CAMPATH, or it can be done in the lab by using columns. Now, it's important because patients who are T-cell depleted have the lowest risk of immunopathology, such as diffuse alveolar hemorrhage and GVHD, but they have the highest risk of post-allograft infection. GVHD is the fifth question, really. Does the patient have active GVHD? Is it resistant to steroids? And what immunosuppressive are they on? And that's because active GVHD is consistently shown to be prognostic in patients admitted to intensive care units. Patients with active GVHD who require mechanical ventilation unfortunately have a mortality in excess of 80%. The final question is really what is their prior colonisation and infectious status? And this really incorporates both bacteria, fungi and viruses. I guess from a bacteria point of view to help guide empiric antibiotic therapy. From an invasive fungal infection point of view, this is fairly consistently shown to be prognostic in patients post-bone marrow transplant admitted to intensive care units, particularly when it's a non-aspergillus species and when it's a non-pulmonary source. A viral infection such as CMV are particularly pertinent when patients have prolonged CMV viremia. So the odd CMV positive result on peripheral blood is unlikely to lead to CMV disease, while someone who has persistent high-level CMV results despite suppressive therapy for over 4 weeks may well be having their respiratory failure from CMV pneumonitis. So the 6 questions really are, is it an autograft or an allograft? What's the donor source to help guide what that risk of GVHD and immunopathology may be? What phase are they post-transplant? And that's possibly one of the key things from the outset before you even see the patient, which gives you an idea what they should and shouldn't be expecting at this stage. When is engraftment anticipated? What's the conditioning regimen? Is it T-cell depleted? Have they got graft versus host disease? And what sort of bugs have they had? What seems to be least important is actually how old they are, what their indication for transplant is, and what the estimated prognosis of their hematological malignancy pre-transplant was. The obvious exclusion there is patients who have actively relapsed post-transplant have a very poor prognosis. But the key factors for prognosis are really graft versus host disease, invasive fungal infection, number of organ system failures, and the response of those organ system failures to the initial measures in the first 72 hours of admission to ICU. So can we now sort of make a bit more sense of these crazy acronyms looking at these 3 cases? Well, the first patient is middle-aged, has had an allogeneic transplant, but has had ATGAM. So that tells you that the patient is T-cell depleted and they're very early on. So any sort of respiratory failure that they may well have is less likely to be GVHD. It's less likely to be diffuse alveolar hemorrhage. It's very likely to be an infectious-driven process or acute pulmonary edema or a drug-related toxicity. So the differential diagnosis right from the outset, even before you've even stood at the end of the bed and seen the patient, is quite different. For the second case, you've got a similar middle-aged patient who has essentially the full house of risk factors for diffuse alveolar hemorrhage. They are at the time of engraftment, about day 11, they've had total body irradiation and they're a mismatched unrelated donor. So diffuse alveolar hemorrhage is the top of the list. And the last one is a patient who's very early after a haploidentical transplant. So it's too early for GVHD. Infection could be a possibility, but this phenomenon of cytokine release syndrome is important to pull out, particularly because it's got a specific therapy. So I'm going to leave it there, and hopefully that is of some help in trying to make sense of what can be a difficult area to understand all these letters and the importance of T-cell depletion and the conditioning.